So I'll be presenting an oral abstract later today, basically analysis of dexamethasone, I'll call it DEX, in two large SWOG cooperative group studies, SO777 and S1211. The idea, as many of you listening to this know, is that we as myeloma physicians are addicted to dexamethasone. We've used dexamethasone for decades for our patients, and there was a seminal cooperative group study a decade ago that showed that basically 40 milligrams once-ish per week or 20 milligrams twice per week was better than the older regimen of 40, 40, 40, 40, pause, 40, 40, 40, 40, etc. However, we've not really looked at that question since then, and in real life, many of my patients cannot tolerate Dex 40 even once weekly. They have insomnia, they have weight gain, they have irritability. We've published primarily, I'm first author on this, of showing that chronic dexamethasone exposure is associated with cataracts, like visually significant cataracts, preventing patients from driving. So it's a big deal. And so as a first step to kind of understand, does Dex really matter? We went back and looked at two of these large cooperative group studies. One was VRD versus RD, one was ELO-VRD versus VRD, and we looked on trial. So it's very difficult to reduce medications dosing on trial, but we did it. It was allowed on both of these protocols, and we looked at for the patients where the dexamethasone was reduced at any point during induction versus those who maintained full dose intensity, was there any difference in PFS or OS? Normally in life, we're looking for one curve to look better than the other. Here, I was looking for no difference between them, and that's indeed what we found. If you look at all comers who had any dex dose reductions during induction, they did just as well as those who maintained full dose intensity. We did look at the subset of patients who had major dose reductions that had almost dropped entirely, or over 50%. Again, these studies were done between 2018 and 2015 or so. So back then, we didn't really have this push for steroid-sparing regimens the way we do now. And those patients, we did see a decreased PFS for sure. Those patients were frailer and sicker than their comparts. But in general, I think the takeaway for this, for academic doctors, I think there's really not much of a takeaway, because I should add that we also found that basically over 2/3 of patients on trials were getting their dexamethasone dose reduced. And in real life, that's exactly what happens. None of my patients are kept on 40 milligrams weekly. However, in the community, many of our colleagues who don't see as much myeloma, don't know that we're allowed to do this, they're maintaining their patients on 40 indefinitely. Again, weight gain, cataracts, insomnia, all these bad things. And in the era of modern therapies, I don't think dexamethasone is that important anymore. This is a retrospective analysis. Well, it's prospective data, but it's an unplanned post hoc analysis. So we're looking at prospective ways to validate this. Either Dex 20 milligrams for everybody, regardless of age or fitness, 20 milligrams, not 40, or a de-escalation strategy where if you start at full dose Dex, because Dex does have some value for bone pain, for infusion reaction prophylaxis, and so forth, but that's really in the beginning. Once patients start to have a response after 1 or 2 months, dropping the Dex entirely is our goal, and hopefully more studies are coming in that direction.